Very good evening. I'm Dr. Prasad, Emergency Medicine Consultant at Hitec City Yashoda Hospitals, Hyderabad. So today I welcome you all to the every Friday webinar series. Today we have come with a very interesting topic called Syncope. So which is a very common presentations to the emergency. Every day we see at least one case in a shift. So I would like to invite now the speaker, Dr. Malaya Mishra, who is the HOD Emergency Medicine, Secunderabad Yashoda Hospitals. So over to you, sir.
Hello, hi, good evening all. I think my voice is audible. Thank you,
Yes.
Dr. Prasad, for nice introductions. So, as all of you know, this syncope is a very interesting topics. As Dr. Prasad has clearly mentioned, in our emergency room, like this is a common chief complaints we encounter in a daily basis. So, they're having a broad differentials that ranges from benign to acutely life-threatening conditions. So for all syncope evaluations, ECG is a must. Investigations, we should do it in an emergency room, and that will give us many clues. So likewise, I'll be covering a few ECGs here in these sessions. We all have to remember one small mnemonics that is called ABCD, left to right. So here we can have it like to recall all 7 ECG patterns for high risk syncopes. So as you said, ABCD for every emergency physicians, A stands for airway and B stands for breathing. Likewise, in ECGs also, there's a mnemonic called ABCD, left to right. A stands for AV nodal block, and B stands for very difficult to treat. That condition is called Brugada. C stands for QTC prolongations. D stands for delta waves that normally we often get to see in WPW syndromes. And E stands for epsilon waves. That is a typical condition that's called arrhythmogenic right ventricular cardiomyopathies. Then I'll be talking something about left ventricular hypertrophies and right ventricular strain patterns. So moving forward, slides. So this is called transient loss of consciousness. So what happened in transient loss of consciousness? Basically, this term itself is called transient. So there will be it can be simple as a benign kind of symptoms. You can say it's a faint kind of symptoms or a symptoms of an underlying disease that may lead to sudden cardiac death, or it may not be a syncope at all. Okay. So syncope, as I said, is a symptom, is not a diagnosis. Many of the times it is self-limited in nature, and very of the times it is like postural in conditions, postural tone. It is rapidly onset and having variable warning symptoms. So it is spontaneous, complete, and usually prompt recovery without sometimes medical or surgical interventions. Okay. So we should always have in a back of a mind that should be underlying mechanism why the person has landed into syncope. There should be a transient global cerebral hypoperfusions. Remember these things. There should be global cerebral hypoperfusions in the background. So moving forward, we have this causes of syncope. There are 4 varieties. One is neurally mediated, also called as basically neuroradiological, neurocardiogenic mediated. Basically, it is of vasovagal syncope. Second one is carotid sinus syndromes. Many of the times it is situational, like cough or post-mixturnal. Second variety is orthostatic, drug-induced, many of the times diuretic-induced, alpha-1 blockers, alpha-2 blockers, and ANS failures, autonomic nervous systems failure, primary or secondary cause. Third one is the cardiac arrhythmias, bradyarrhythmias, and tachyarrhythmias. In bradyarrhythmias, like sinonodal dysfunctions or AV nodal blockage. In tachyarrhythmias, ventricular tachycardia, supraventricular tachycardia, long QT syndromes. And the last option that is called structural cardiomyopathies, where we can discuss about acute myocardial infarctions, aortic stenosis, HOCM, hypertrophic obstructive cardiomyopathies, pulmonary hypertensions, and aortic dissections. Having said that, there are many times like it will be unexplained causes, like almost around 1/3 of the cases will be unexplained. So, but don't forget to obtain an ECG. As I earlier mentioned, ECG will give us many clues. Okay. And certain things, there will be mimics like syncope. As example, there will be acute intoxications, like in terms of alcohol intoxicated or drug-induced intoxications, seizures. Sometimes persons might be deprived of sleep, so you'll have related to syncope, sleep disorders. The next one is somatization disorders like psychogenic or pseudosyncope. And the very most common is trauma or concussion type. Second most common is hypoglycemia. And third one is the hyperventilations. So coming to the cardiac syncope causes, as you know, I mentioned arrhythmias being the create a major role for having syncopal episodes. So examples of arrhythmias we'll be having encountered in a daily practice like long QTC syndrome, short QT syndrome, catecholaminergic polymorphic ventricular tachycardia, Brugada syndromes, and WPW syndromes, or Parkinson's White syndromes. Coming to the structural part, hypertrophic obstructive cardiomyopathies, acute myocarditis, arrhythmogenic right ventricular cardiomyopathies, coronary artery anomalies, valvular heart disease like aortic stenosis, and pulmonary hypertensions. So remember, when you are obtaining a ECG, in background of your mind, you should always think about this cardiac syncope and always try to evaluate in this sequence. Like H stands for always try to calculate the heart rate or rhythm, whether it is tachy or brady. Second is electrical conductions. Here you can consider about AB block, WPW, bundle branch block, or long QTCs. Coming to this axis calculations, you always find out it is right axis or left axis or normal axis. And depending upon that, it's a hemi block, left anterior fascicular block or right anterior fascicular block. That all these things you need to discuss. Then coming to the R wave, 4 RA progressions leading to some tamponade effect or some fluid around the pericardial cavities like pericardial effusions or pleural effusions. And early R wave repolarizations changes also you can be seeing, like that is right bundle branch block, WPWs, or certain MIs and pulmonary hypertensions. Coming to this tension part, you always should think about the structural as well. So if you always consider aortic stenosis or hypertrophic obstructive cardiomyopathies changes. Then last one is STT waves. That is for arrhythmogenic right ventricular cardiomyopathies, Brugada, MI, and pulmonary embolisms. So this you can remember by this mnemonics called HEARTS, HEARTS, HEARTS. So moving forward, I have a ECG for you. 20. Can you just make it? I think this is not good. Back. Okay, sorry. So there's a 21 years female. Not able to read actually. Previously well with half an hour of palpitations, pre-syncope and resolved. So you can see it here. Heart rate or rhythm, it is normal sinus rhythm. Electrical conductions, there is short PR with delta wave in the precordial leads. And the axis, you can see lead 1 and AVF, same directions. So normal axis. R wave, there is early progressions. And there is no structural or anything, any tension is there, no LBH pattern. So STT changes, there is mild anterior ST depressions discordant to the delta waves. So what do you think what could be? So this is called classical, it is WPW syndromes. Another one is 80 years female with recurring pre-syncope while sitting posture. You can see it here. So it is sinus bradycardia with left axis deviations. So you can see the axis here, lead 1 and ABF. There are opposite directions, R waves. So it is left axis, and electrical conduction, it is like prolonged PR. You can say it is first degree AB block, with right bundle branch block and left anterior fascicular block. So the tension, there is no LVH pattern or right ventricular strain pattern. So STD changes, there is nothing. So diagnosis it is here is bifascicular block with first degree AB block. Okay. So we have to admit this patient for permanent pacemaker. Moving forward, there is a third ECGs. You can see it here. It's a 25 years male with exertional syncope. So what is this ECG? You can make it easily for this criteria called Lyon criteria. So you can say it for the sum of S waves in V1 or V2 with tallest R waves in V4 or V5. If the sum is more than 35 or greater than this, so always consider that is a pattern for LVH. This is called Lyon criteria. Remember, like there will be structural disease, structural changes will be there, like hypertrophic cardiomyopathies or underlying aortic stenosis, aortic regurgitations, or sometimes mitral regurgitation also having similar kind of pictures. As I said, it is borderline tachycardia. Electrical conduction, it is normal. Axis, you can say it lead 1 and AVF, it is normal. R wave, there is large voltages with deep inferolateral Q waves. And in the tension, it is left ventricular hypertrophy kind of changes. STD changes, there is no changes. And you can get it by ultrasound, POCUS. It could be suggestive of hypertrophic obstructive cardiomyopathies. Moving forward, there is another patient, 70 years old female, history of malignancies, presents with shortness of breath. Shortly after ECG, patient collapsed. So you can easily see here, there are low voltage ECGs. Heart rate or rhythm, it is tachycardia, sinus tachycardia. Electrical conductions, it is normal. Axis, you can easily understood here, lead 1 and AVF. They are having similar directions, R wave, so it is normal. Tension, there is no structural changes are there. STD changes, there is no significant changes. And in the POCUS ultrasound and 2D echo, you can see no pericardial effusion, but RV is more than LV. So patient arrested immediately after the ECG is obtained. ROSC is achieved after giving injection of tissue plasminogen activator, that is RTPS, and CT showed massive pulmonary embolism because background history has a malignancies. Moving forward, this is a classical ECG I was discussing before. This is called 70 years old male, he is unwell. After ECG obtained, patient suddenly collapsed. So what do you think, what could be this is? This is called Brugada syndromes. So here in Brugada, the diagnosis will depend upon the Brugada sign and clinical criteria. So ECG changes, there are very much transient and mortality happens up to be around 10 to 15% per year. So what is the treatment? Definite treatment is implantable cardiovert defibrillator. You can see here, there are three types of Brugada. Type 1 Brugada, basically, will be curved ST segment elevations more than 2 mm in more than one lead of V1 to V3 and by negative T wave reflections. So this is the only ECG abnormality that is potentially diagnostics. I'm telling again, this is a curved ST segment elevations with more than 2 mm in V1 to V3 followed by a negative T wave reflections. This is the only ECG abnormalities is having potentially diagnostic criteria. And other two types are type 2 and type 3. Type 2 has more than 2 mm of saddleback shaped ST elevations. This is a typical called saddleback shaped. And in type 3 can be morphology of either type 1 or type 2, but with less than 2 mm of ST segment elevations. So which is more classical if someone will ask, type 1 Brugada. It is more classical, and the ECG is potentially diagnostics because you can have a curved ST segment elevations with negative T wave reflections. So as I said, heart rate or rhythm, it is normal sinus rhythm. Electrical conductions, you can see it easily here. It is called right bundle branch block. Axis is normal. R wave, there is normal size or poor progressions. Tension, it is normal. Then STT changes, V1 to V2, there will be V1 to V2, you can see it here. There is ST, curved ST elevations with negative T wave reflections, and diagnostic it is Brugada. Patient had ventricular fibrillations, RS shortly after the ECG is obtained and should be cardioverted, admitted for implantable cardiac defibrillator. Next ECGs, there is a 60 years female, chest pain with syncope. So any characteristics findings here, you can see it here. ST depressions in V1, V2 to V3. So this is called clinical significance of posterior wall MI. The posterior infarctions comprises almost 15 to 20% of ST elevation MIs. So usually occurring in the context of inferior or lateral infarctions. This is a mirror image. So you can see whatever joints is there in V1, V2, you just reverse the ECG paper. You can see it. Horizontal ST depressions will become ST elevations. There will be tall upright T waves and tall broad R and Q waves complexes. Next comes lead placement in the posterior leads. So posterior infarctions, it is confirmed by the presence of ST elevations and Q waves in the posterior leads starting from V7 to V9. So V7, where you will fix in the posterior axillary line in the same horizontal plane as V6, then V8 at the tip of scapula, and V9 at the left paraspinal region. Okay, remember V7 should be at the left posterior axillary line, and V8 at the tip of scapula, and V9 at the left paraspinal regions. Then you can see this ST elevation changes. Moving forward, like I said, you can say this heart rate or rhythm, it is sinus bradycardia features. Electrical conduction is normal, axis is normal, R wave is normal size, tension, that is nothing is there, but ST changes, anterior ST depressions with T wave inversions. When you reverse this ECG paper, you can say it here, it is a basically posterior wall MI. So here there will be no early R waves or right axis to suggest pulmonary hypertensions, no other features to suggest pulmonary embolisms, no epsilon waves suggest AVNRD. Posterior leads showed ST elevations, and cath labs need to be activated, and patient need to shift to the cath lab immediately, and there is a occlusion in the left circumflex arteries. Moving forward, there is a 20 years old man with palpitations and syncope, hemodynamically unstable. There is a history of elder brother died of sudden cardiac death at the age of 28 years. So by looking at this ECG, what we'll do? We'll immediately go for cardioversions, right? Post cardioversions, these are the changes. You can see it here, typical things. What is this called? This is called epsilon waves. Okay. This is the second most common cause of sudden cardiac death in young people after HOCM. That is accounting for almost 10 to 15%. So what is the treatment for this? This is called antiarrhythmic, basically plus minus anticoagulant. And many of times patient require radiofrequency ablations and implantable cardiac defibrillator. So it's a typical way ECG changes. It's called epsilon wave. You have to remember it's happened to be in arrhythmogenic ventricular dysplasia. So epsilon wave, which is the most specific findings around 50%. T wave inversions in V1 to V3 in the absence of RBBB. Prolonged S wave of strokes and localizes of QRS widening and paroxysmal ventricular tachycardia with LBB morphology. So the classical findings here is epsilon wave. So remember this. Next patient, 34 years old male, presented with syncope, BP not recordable. He has a previous history of syncopal attack. So looking at this ECGs, so what we will do? We will do cardiovert, right? So post cardiovert, this is the changes. Any guesses for this? There are classical findings here. These are called delta waves. Okay. So remember, this is called WPW, whole Parkinson-White syndromes. So here you can see the PR interval is less than 120 milliseconds. There will be typical classical features that is called delta waves. Many of the times it will be prolonged QRS more than 110 milliseconds, and there will be discordant ST segment and T wave changes. Okay. Here you can easily identify. Yeah. So here remember, this is called WPW. It happens in the pre-excitation phase. Typical waves will be present. That is called delta waves. This is the classical findings. You can make it here. And in this slide, it is called epsilon waves. This is called post-excitation phase. That is AVNRD. So the difference between delta waves, WPW and epsilon waves in AVNRD. So remember, in delta waves, it is pre-excitation phase, whereas in AVNRD, it is the post-excitation phase, and the classical features to be remembered here is epsilon waves. Moving forward, there is a 5 years female with complaints of recurrent syncope. You can see the classical changes here. So any guesses? This is P. This is P. This is QRST. This is P, QRST. So there is prolonged QTC. You can appreciate here. This is called long QTC syndrome. So there are certain drugs which are responsible for long QTC syndrome. What are the drugs? It is antiarrhythmic drugs, tricyclic antidepressants, many antibiotics, antifungals, okay, particularly macrolides, and SSRIs, atypical antipsychotics, droperidol, haloperidols, methadone, and commonly used drugs in emergency room, that is ondansetron. So you will have a prolonged QTC syndrome. And sometimes it will be genetic disorder also, like some channelopathies, like sodium channelopathies or potassium channelopathies. So remember, ECG evident, there will be more than 440 milliseconds in males found to have it is prolonged QTC. And if it is more than 460 milliseconds in females, we used to call prolonged QTC. Okay. So hallmark arrhythmias is torsades de pointis, and primary presenting symptoms will be syncope. So it is the one of the cause for sudden cardiac death in children or in young adults. And sometimes it happens to be because of some deficiency or some electrolyte imbalance of calcium, magnesium, and potassium as well. Moving forward, there is another ECGs. 60 years old male having syncope in the emergency room found to have systolic BP of 70. This is the first ECG. What is this? This is called ventricular tachycardia, right? So post conversions, you can see it here. There is called left anterior fascicular block with RBBB pattern, right? So ventricular tachycardia converted into junctional rhythms. And electrical conduction, it is RBBB with left anterior fascicular block. Axis, you can see it here. It is left axis. It's R waves. The directions are opposite in each other. So RVFs is RBVB superimposed on another QFs, a delayed RVF progressions, tension, there is nothing. So ST changes, diffuse ST depressions with reciprocal elevations in AVR. This pattern can be seen in post-cardio versions. And this patient also had anterior QFs, that is called bifascicular block. RBVB with left anterior fascicular block. Okay. So when we will repeat this ECG, it will be looking like this. So here you can say this is normal sinus rhythm with sometimes premature ventricular complexes are there. This one, okay, and there will be electrical conductions resolved RBBB with ongoing left anterior fascicular block, and RVFs there is anterior QFs, ST changes, ongoing diffuse ST depressions with reciprocal ST elevations in AVR. You can see it here. There is elevation in the AVR, and dynamic RBBB with left anterior fascicular block with ST elevations is associated with left main or LAD, proximal LAD occlusions. So cath lab need to be activated urgently and we'll have a LAD occlusions. Okay. So having said that, so left main ST elevations in AVR, what does it signify? There should be left main coronary artery occlusions, proximal LAD. And sometimes it will be reverse lead placement also. That need to be well taken care. Suppose someone has wrongly placed the lead, you will have a ST elevation in AVR. That is most commonly encountered. But the pathological condition here it could be a left main coronary artery disease, proximal LAD occlusions, or severe triple vessel disease. Okay, and many of the times post resuscitations, whether the patient is having hypoxia or hypotensions, you will have this kind of changes. There will be ST elevation in AVR. Okay. So the take-home points here it is, history is very, very crucial for identifying these high-risk factors. Always try to obtain a definite history. Time should be mentioned properly. And ECG is a very important investigation for every emergency physicians. All type of patients coming to our emergency, it will take hardly 5 minutes to obtain a ECG. If you can able to read that ECG, it will give us many clues. So systemic ECG interpretations help us in interpretation of abnormalities like all this, what I have discussed, 7 varieties of high risk of syncope. And of course, focus, point of care ultrasound, 2D echo machines is a useful adjunct in all emergency room settings. Okay. Thank you so much. If you have any queries, I'll be more happy to answer all those.
Thank you. It's a very crisp talk. Thank you. And I think we don't have any questions in the chat box as of now. So I would like to add one more thing, like syncope, any patient coming with a syncope after ruling out the life-threatening conditions, it is ideal way, or it's a, I would say it's a good practice to look at the postural blood pressure whenever a
Yes.
patient comes with syncope. So ideally after ruling out all the life-threatening causes, because if you do a postural blood pressure for a patient who is having VT or any of these rhythms, so it will be more disastrous. So once ruling out the ABCs are in control, and once you have taken an ECG and initial ABG and all, so once the major things are ruled out, it's a standard practice to look for the postural blood pressure.
Yes.
Only this I wanted to add. Yeah, I think.
Thank you. Thank you so much for the input.
Yeah. So if there are no questions, then we'll take a leave. Once again, thank you, Dr. Mishra, for enlightening us with a good ECG resources, actually. Yeah.
Thank you. Thank you so much, Dr. Prasad. It was a wonderful session here. And I think it is for the all emergency physicians. It is very much useful to read all the ECGs, and in a daily practice, it will be helpful. Particularly, as you said early in the session, the syncopal presentations is very, very common for all emergency physicians should be able to read these ECGs and try to figure out these high risk ECGs, what I have displayed. So particularly, we have encountered here in Secunderabad WPW very often. Okay. And arrhythmogenic right ventricular dysplasia also. So it is very, very common, I think. And particularly, we may forget to evaluate this electrolyte imbalances, particularly this calcium, potassium, and magnesium levels. That is also very, very important to understand. And always make sure to do a focus study. Whatever be the conditions, when the patient land up in an emergency, should always do a head-to-toe examinations. Along with this, you can use an adjunct like focus, point of care ultrasound. We can do echo screening. How is the LV functioning? How is the IVCs? Okay, that needs to be in practice day and out whenever we are seeing any critical patients in emergency room. That is what the message is. Once you see and you be familiar with this kind of ECGs, it will not be difficult for you to read. But yes, of course, you need the basics and how it should read the ECGs and all that need to be really helpful in a daily practice.
Yeah. Eyes can only see what brain can comprehend. So now you have put something
Exactly.
inputs in the brain. So I think they will be looking with a good tunnel vision, particularly with this, at least heart's code, at least the heart's code, they should be able to see in all the ECGs, just to see that at least these are not there or there, at least.
Yes, yes.
Well,
So I think there's a connection issue. Shall we close?
Okay. Okay. Thank you. Thank you so much. Thank you once again, Yashoda Hospital, for giving this opportunity. And it's my pleasure having here and having these sessions of syncopal ECGs. Thank you once again, Yashoda management people and Yashoda Hospital, Secunderabad, and Dr. Saujanya ma'am for giving me this opportunity on this platform of weekly webinar sessions. Thank you. Thank you so much.